All right, let's begin with our daily conference regarding the COVID disease, which is caused by the new coronavirus SARS-CoV-2 around the world. Today we'll basically just be giving the technical report, and then we can begin with the Q&A period. Dr. Salomia, please, would you begin? Thank you, Deputy Secretary. Good evening, everyone. Let's begin with the international landscape. We observed that the parameter that we've been observing, which is the active percentage of cases, out of all of the infected cases around the world, which of them, what percentage is being active during the past 14 days? That is the number we've had in mind for the last couple of weeks, and it's continuing to decrease. Now it is at a 53%. In contrast, there was an increase in the fatality rate worldwide, which is now at a 6.7. And let's look at this data in a different form so we can have a better look at the distribution of the pandemic per region. So as we can see, the European region and the Americas remain to be the larger areas in which this pandemic is being active, and it is to be expected that the Americas will eventually replace Europe and the European region in the representation in this chart. Now let's look at the national landscape. We have the map of the Mexican territory, and it is indicated by color which states have a higher concentration of the epidemic. To this day, we have 6,875 confirmed cases, meaning that these cases have been submitted to clinical testing in a laboratory with the PCR method, and 6,875 of them have come out positive. But we have 13,364 that have been negative in their results, and currently we have 28,126 suspect cases. To this day we have 546 deaths, unfortunately, out of a total of studied cases of over 48,000 cases. Now let's look at these numbers through a different graphic representation. Here we have the bar graph per state, in which we can observe the number of cases reported by each state on the online unified database that we have for this purpose. Here we have another map of the national territory, but here we are representing the accumulated incidence rate. We are seeing a similar pattern like the one we've been observing in past days, but this of course will vary over time as the epidemic moves forward. And of course, the ones that are in a darker shade of green are the states that have a higher incidence rate, accumulated incidence rate. And this variation is due, of course, to the different populations of each state. Some of them have a higher number of inhabitants, some of them have smaller populations. Here we have the same accumulated incidence rate in the form of a bar graph, and we can see specifically which is the incidence in each state per 100,000 inhabitants. Here we have the other more specific distribution of the case occurrence per municipality. This is important to emphasize because this information is of public access. Anyone can access this information at any time, and this information is being updated daily after 2 p.m. And also there are some updates happening during the conference. We would like to thank all the collaboration and great joint work that we've had with institutions such as CONACYT, EOLAB, and others that have contributed to this map being updated constantly. This is the link to access this map it's showing on screen right now, and it is better to access it online through a computer because you can interact with the platform and you can zoom in or zoom out, and then you can go to specific municipalities and have the specific amount of confirmed cases, so it's just more user friendly. And it is easier to identify which municipalities are next to which municipalities. Because if you remember, the first activity that we will have on May the 17th that has to do with municipalities that haven't had any cases or that do not neighbor any municipalities that have had confirmed cases, and that those activities, the implementation of those activities, and the first lifting of some restrictions, we can monitor these measures when they happen through this platform. Here we have we have 501 municipalities out of the 2,457 that are in total in our country. 500 of them, meaning 20%, have shown at least one confirmed case of COVID-19. And we are very happy to share this information with you, and we encourage the population to access it and check it for themselves. Here we have distribution per age group. This is a distribution that has been rather stable during the past 2 or even 3 weeks. The 6,875 cases have maintained a normal proportion. When talking about the gender proportion, 58% of the cases are male, 42 are female, and as you know, the green bars represent outpatients and the yellow bars represent inpatients. So the older the citizen is, the more likely they are to finding themselves in the need of being hospitalized. Here we can see, talking about the hospitalized patients, we can see what is the degree of impact that these patients have had, meaning which is the state that was registered when they first got hospitalized. So 63% were outpatients, meaning they just went into the hospital for testing. Then 10% are hospitalized stable patients. We have 20% in severe condition and almost 5% of intubated cases. Remember that this proportion these percentages are calculated on the basis of the total amount of confirmed cases, which is 6,875. We also have a different proportion, which is based or calculated on the basis of the amount of suspect cases, and this will show some variation. This is important to emphasize, because as you know, all the different state governors are constantly updating their information and reporting their own cases. And state governors are also expressing in their own terms, through their own means, the amount of cases confirmed within their states. And sometimes it can seem like there is some discrepancy in the percentages and the data they show. But it's important to specify which cases are we talking about. Are we talking about confirmed cases or suspect cases? Which universe are we using to calculate these percentages? Because depending on these universes, the percentages could show some variation. So here we are calculating the percentages using the universe of confirmed cases. And remember, these cases are registered in the platform that we have, the unified database, and it is the responsibility of each state government to input this data into the unified database so we can have access to it and analyze it. Of course, this is also a process that happens with the help of different laboratories, medical units, and analysis institutions that help to accurately capture this information and share it with us so we can present these daily reports to you. So we have, for example, 153 fatalities that are currently under suspect status, and tomorrow we will have confirmation of whether they are COVID associated deaths or not. Here we have the representation of the fatalities we've had so far, taking as a point of reference the date in which they occurred, in which these people unfortunately died. The curve is the accumulated number of cases, and the bars, we can see the daily newly confirmed fatalities we've had so far. Remember the trend overall has been somewhat stable. We haven't seen a turning point so far, but it is important to continue to monitor this trend. Here we have the comorbidity chart, meaning all those conditions that were associated closely to these fatalities. The leading three continue to be hypertension, diabetes, and obesity. And here we have the distribution of the fatalities per age group: under 25, 25 to 59, and over 60. As you can see, we have the highest fatality rate on the group over 60, and it is important to emphasize that a lot of these people, on top of belonging to a elderly to the elderly, on top of being senior citizens, they also presented some comorbidity factors such as diabetes, hypertension, obesity, etc. The fatality rate is rather stable in the group of young adults, in the group of 25 to 59 years old, hasn't shown any significant variation. And the fatality rate has gone up slightly on the over 60 age group. Here we have the distribution of the fatalities per state. We have represented here the number of fatalities reported and also the fatality rate calculated on the basis of their populations and on the number of confirmed cases. Remember, the fatality rate is calculated with relation with the number of confirmed cases. We have an average fatality rate of 7.94, but remember that yesterday it was explained that we have an estimated number of cases, which is different from the confirmed number of cases. We have over 55,000 estimated cases, so the consequence of this is that we also have an estimated number for the fatality rate, and that one is much lower. Remember that this estimation also has a delay of 2 weeks, and this is not because it takes us 2 weeks to do the calculations. The calculations are done in 4 hours, but because of the in order to be able to do this estimation, we need information from all of 26,000 medical units over the country. And this process, because of the amount of units and because of the methodology that we use, takes a while. So it takes about 7 or 8 days, and then in order to be able to present it to the public, it takes a few more days. So that's why we have a 2-week delay. But every week we will be updating the number of estimated cases. So if we calculate on the basis of the estimated cases, the estimated fatality rate is less than 1%, 0.90 something, I think. Here we have the mortality rate. Remember, the mortality is calculated with relation to the population, and it varies from 1.8 to 0.43, and this depends on which state we are talking about. Here we have the positive result rate, meaning out of all the tested patients that are confirmed to have some sort of infectious respiratory disease, what percentage of them come out as COVID-19 positive cases. So we are still on week 16. Last week we closed at a 23.07, and so far we are at a 17.51. So we'll see how the week closes. But remember, as the transmission rate goes up, and thinking that we are probably going to be entering phase 3 in a few days, then this percentage it is expected to go up. We have a number of cases that have recovered so far. This is the number of recovered patients, 2,627 so far, and they represent 38% of the overall confirmed case number. And of course, some people that are close to recovering are still in the last stages of the recovery phase. So what we've seen is this proportion is stable, and the good news is more and more people are recovering from this disease every day. Here we have the epidemic curve of suspect cases. So if you remember the chart we showed about the suspect cases, this is the same data represented in the form of a chart. This is the behavior of the trend regarding the suspect cases. We had seen a decrease in the past few days, and now it is going back up. So this is something that we have to continue to monitor every day. So the trend continues to be an upward trend. Finally, we have the accumulated case epidemic curve, which begins with the first case and ends so far with 6,875. And we also have the orange bars that represent the number of newly confirmed cases every day. We have a slight increase compared to yesterday. We will have to wait for tomorrow to see if this trend continues to go up or will stabilize. That would be my report for today. Thank you. Thank you, Dr. José Luis Salomía, General Director of Epidemiology. Let's begin with the Q&A question, with the Q&A period. You, and then you, and you, and then you. There was a journalist that wanted to ask a question yesterday, but I don't think he's here today. Hello, good evening. April the 4th, the newspaper Basta gave information about 4 infected patients in the northern prison, national prison. Today, there was a report of an infected patient in this prison that died because of COVID. And you talk about this? I don't have the information. Do you have the information regarding this? Yes. Yes. Can you hear me? Yes. Yes, all right. What I can say about this is that there is indeed an intervention that we are doing in collaboration with the Mexico City government that is aimed at preventing any outbreaks inside prisons, meaning that they have a specific protocol to test all the new inmates. Yesterday afternoon, we had the same package of these tests. We have 52 tests that were applied to new inmates after having studied the suspect cases within the inmates. And out of this first package of 52 tests, all of them were negative, meaning we didn't have any confirmed cases. This will continue. Today there will be another group of tests that will arrive, and every day we will have new tests. So far, of the information we have, at least out of this first group, because these cases are not reported on the same platform because they are not symptomatic cases. In order to enter the platform that we're using, you have to fulfill an operational definition, which means the patient has to meet the specified known symptoms like headache, coughing, etc. because this is a protocol to prevent outbreaks in the interior of the prisons. So, because this is a special protocol, they will test a sample of the new inmates, disregarding whether they have symptoms or not. So far we have 52 results that are all negative, and if we have any positive results, we will be presenting the information to the Mexico City government, and they will present it to you. Thank you. I want to ask about the municipalities that will be lifting the quarantine restrictions. I think people haven't quite understood how this process of gradually lifting the restrictions is going to happen. And you go into further detail about this? Yes. Well, it is not that people do not quite get it yet, it's that we haven't defined the specifics of it. This will start happening on May 16th. So we are still in the definition process of making, I mean, we're talking about a month from now, and starting now, a month in advance, we are working on defining the specifics about the lifting of restrictions, but we haven't defined them so far. Yesterday we talked about a pre-identification of the relation that exists within municipalities with respect to the transmission of COVID. And as we move forward and eventually reach May the 17th, we will be working and analyzing the results of the massive mitigation measures. The massive mitigation measures continue. Now, the moment of making the choices of which municipalities can lift the restrictions and which municipalities cannot will depend on the data that we have in the upcoming weeks and on the different behavior that we observe in each municipality. For example, if in the period that goes from today to May the 17th, there is a municipality that didn't have any transmission before, but then it has transmission, and this transmission is not controlled, then obviously we will not be lifting restrictions in this municipality. But if, on the contrary, there is a municipality that is identified to have high transmission today, but during the next 4 weeks this transmission is controlled, then we will consider lifting restrictions there. This will be handled by the Ministry of Health. All right, 2 here and 2 over there. Good evening, doctors. I would like to ask 2 questions. First of all, about what Governor Bonilla said about the fatalities. A few minutes ago, Dr. Alomia made some specifications, but we want to know to which extent it is the responsibility of the state authorities, meaning the report of these fatalities, because these fatalities have to be confirmed by a laboratory. Is it not true? Can you talk about it so we don't have these discussions in the public space? And also, I want to ask you, when you presented this map that was presented yesterday morning, we saw some municipalities in red. So in those municipalities that were presented in red, can we know what is the occupation level in medical units for intensive care in those municipalities? What is the current status of occupation, so to speak, of medical units? 30%, 40%? Because there's been reports of many cities in which people are starting to go out again. Something is happening. Maybe do you have the same perception or not? Thank you, Laura. First, the second question, and then I'll give the first question to Dr. Alomia. With regards to your second question, it is a very important question. At this time, we said this about 8 days ago, it is possible that you, and I'm talking to you as a citizen at home, it is possible that you don't have the perception that there is a health problem because you're not seeing it. Maybe you don't know anyone in particular who has been infected with COVID. Maybe you don't have any relatives or friends or neighbors that have COVID, and maybe you have a perception that this is a very remote, far away problem, or even that it is highly unlikely that it will affect you in any way. We want to emphasize that is not the case. All of us in this country have the possibility and a substantial probability of being infected with this new coronavirus and get the COVID disease. If this happens and the person who is infected is less than 60 years old, is not obese, is not a pregnant woman, and does not have any chronic condition, the most likely scenario is that this disease will last 10 to 14 days and they will have a natural recovery. But if you are a person that are obese, and that is 3/4 of the Mexican population, either overweight or obese, or if you have hypertension, or if you have diabetes, or even if your relatives are diabetic and you are at risk of being diabetic without even knowing it, or if you're a pregnant woman, then it is there is a high risk of you having a disease that would surprise you and could have a fatal outcome. We do not want this to happen to anyone. So that's why we have insisted that you stay at home. It is clear to us that there is a number of activities that you were all used to engaging in, and we know that there is a necessity of people to go out, maybe because they have to go out to work, or maybe because they had some social commitments or work commitments. We understand this. This is not a desirable situation. But if we don't abide by these mitigation measures that can be summarized with the phrase stay at home, then what is going to happen is that the contagion will go up, and this will affect you, every one of you, and all of the people you know. This is not desirable for anyone. What happened in the European countries, not all of them, but a good number of them, is that they were caught by surprise by this epidemic. So they thought this was an epidemic that could be contained, and they continued to circulate in the public space for too long. And when they tried to do something about it, it was too late. So thank you for this question. Let me ask you at home, be aware of this. Stay at home. To the extent that we stay at home, keep our safe distance, avoid meeting with other people, that is the extent to which we'll be able to successfully come out of this epidemic. If we don't do so, we're going to suffer the consequences in our health and also in our daily lives, including the economic dimension of our lives. So please, let's be disciplined and all together come out of this. Regarding about the functioning of the National Epidemiological Vigilance System and the commentary of Governor Bonilla, I want to say first about Governor Bonilla what I've been saying about all governors. They deserve all of our respect. They are the authorities, the health authorities in their states, and the general health law in our country contemplates what is called in law terms what is called the concurrency, which means there is a shared responsibility, and we are both, the federal authorities and the state authorities are both responsible for ensuring the population's health. But the law is very specific in which parts correspond to the state governor and which parts correspond to the federal government. And when it comes to the epidemiological vigilance, model, it is specified on the Section 8, Article 134 to 138 of the General Health Law, what are the conditions under which this system of vigilance must operate. And we have detailed descriptions of what are the different responsibilities of the different technical and administrative levels of the national health system. So we have hospitals, we have different levels. We have hospitals and medical units. We have another level that are the administrative offices that belong to each state and they correspond to the municipal level. Then we have the state level per se, which is an office that is directly subordinated to the governor. And then we have the federal offices of the National System for the Epidemiological Vigilance. And the director is Dr. Alomia. So the process of generating this epidemiological data will be explained by Dr. Alomia, so you understand who generates this data, who needs to collect this data, and where is this data, and why is the data not where it should be. Thank you, Deputy Secretary. I just want to emphasize that the SINAE community, the national system for epidemiological vigilance, it's a very, very active working community, and now it's usually very active, but now that we are in a pandemic, it's especially active. So I want to thank all of my colleagues and all of the people that are working with us every day, not only at offices but also on the field, doing visits to patients, monitoring outbreaks, confirming that the data is correctly collected, etc. They are actively working every day, including weekends. They haven't had any days off, any vacations since this started. And I want to say this because that is where the most important work is being done, on the local level. These professionals, these health sector professionals, are locally interviewing the patients, collecting the data, and carrying on the case studies, integrating all the variables, identifying the people, their relevant information, their transportation histories, their symptoms, their comorbidity conditions. All the information that we are presenting every day on the technical report is thanks to someone in a community, in a neighborhood, that was at some point with a case study on their hand and talking directly to the patients, either in a consultation room or on the field. And then after collecting this data, they report this data to an online system. All of our epidemiologists have internet connection and a device through which they can access the online database and input their data. They all have a specific password and a specific username, the people who have been designated to generate this report, and through this system, all of the information that was collected from the patient enters the system. In the moment that they input the system and click on the button to notify and to send, in this moment all this information enters the federal database, and this database is accessible by all levels of authority, state authorities, federal authorities, institutions all over the country. So each of them can have access to this information, and each of them can prepare their own presentations, their own analytic products as they see fit. Sometimes maybe we think that maybe the state report sometimes are more visible in the media, or the federal reports, but also the municipal reports are happening all the time, and the local reports are happening all the time, and there are people who are reporting constantly all of this information on all levels. Now, there is a second step, which is when we take the sample to do the testing, the sample is transported to the laboratory in which it will be analyzed. Remember, we have federal laboratories, but we also have regional laboratories. This is a strategy implemented by the National Social Security Institute that involves big laboratories and medium-sized laboratories. There are also laboratories that are inside highly specialized hospitals, and over the years they have also developed the capabilities of building big and highly equipped laboratories in which these tests can be analyzed. So once the laboratory processes the sample and tests it and has a result, then they enter this same platform, SysBer, and also thank you to all of these operators within, and the chemists and the biologists and all the professionals working inside the laboratories. Thank you so much for your hard work, because you are also spending entire days, entire nights processing tests so the results can come out as quickly as possible, and then the relevant measures can be adopted. And they are the ones who are entering directly the platform and capturing the data and inputting the data. Either that is whether that is a positive or a negative result, they have to input it. Remember that the Sentinel model means that if it's negative, that is not enough. Then they have to test it for other viruses to determine which virus is responsible for the infection. Because the idea is to always have the most precise result possible, to know which microorganism was to blame for this infection. So this is a very complete system of local and national and state level networks, and it all originates at the local level in the states. The states themselves are the ones who either collect their data, who input their data in the platform, who analyze their data, and it is all part of a very of a highly systematic process. So our duty on the federal level of authority, beyond coordinating everyone and beyond publishing guidelines for the overall functioning of the system, is also to enter this platform, and with all of the information that is presented there, we can extract this information that was presented by all of the different states, and then we prepare the presentations that we present to you every day, and also analyze this data for the design of different measures. Thank you. The National Network of Laboratories, last time I checked, had 81 evaluated laboratories. Thank you. Good evening. Dr. Alomia, I want to ask you if the population base that you were talking about is the answer to the question that of why there are no cases in some municipalities. And another question, I've been a witness, unfortunately, of some aggression against doctors and medical practitioners. Where can they denounce these behaviors and make sure that the responsible people are punished? And I don't want to be pessimistic or anything, but what would happen if we have an earthquake here in Mexico? What is the protocol in that case? Talking about the aggressions towards the health personnel, we have expressed repeatedly our outrage and our concern regarding these behaviors that have occurred in some regions of the country. This, as we have said before, represents a very unfair and advantageous situation, not only in relation to the victims, and we want to express all of our admiration and respect for, in general, for all of the health workers, but also because of these, with regards to these workers that have been subject to aggression. But it is not only a reprehensible conduct, it's also a crime. So anyone who is a health worker or whoever and is attacked in any way, he has the right or she has the right to go to the closest police station and denounce this crime, and then measures must be adopted by the local authority. And yes, regarding the possibility of an earthquake, that is of course a possibility. And Mexico is a territory, because of geological reasons, of high seismic activity, so it is definitely possible. In, in general, hospitals have a protocol that was established in 2008 that was advanced by the Pan American Association for Health that moved forward a program that was called Safe Hospital. And this is basically a set of protocols and guidelines that inform us of the proper measures to be adopted in the case of an emergency, such as an earthquake, for example. So we have those guidelines, those general guidelines. Medical personnel know where to find them and how to react. But of course, let's hope that that doesn't happen. And if someone has COVID and they are at the isolation period in their own homes, and then suddenly an earthquake begins to take place, what you can do is put on your mask. We are assuming that the people who are infected with COVID and are isolating at home have a face mask. So put on your mask, go out, wait for it to pass, and then go back, wash your hands. And talking about the population base, we're talking about how to calculate the accumulated incidence rate, because this rate is usually calculated on the basis of 100 and 1,000 inhabitants. But in the moment a municipality has one confirmed case, then this municipality appears in the map and it starts being part of the statistic. This is disregarding whether the municipality has small population or a high population. The moment a municipality shows one confirmed case, it will show on the map. And as to why some municipalities have cases and why don't, this is totally depending. This is a consequence of the natural development of the epidemic. This is the way it happens. Usually we see variation, significant variation across different regions because of mobility related reasons, population related reasons, or maybe there are certain social conducts that are unique to them. So it is normal to have this variation, but the fact that a municipality doesn't have a case so far doesn't mean they cannot get a case, and that is why we are constantly monitoring all of them. So the recommendation is the same one. If you start to exhibit some mild symptoms, stay at home, call our phone assistance lines, and that way we can reduce the rate of transmission. And even these municipalities that have no confirmed cases whatsoever, they need to abide by these massive mitigation measures, because in that way they can ensure, or at least increase the probability of not showing any cases in the future. Yes, I want to ask about whether there has been a there has been miscommunication between governors and the federal authorities, because we've had repeated episodes of unfortunate declarations by different governors during the past few days. So, because many of these measures require close cooperation between the authorities, for example, with the new law that prohibits the cremation of dead bodies, it specifies that it will need close cooperation. So, can you talk about that? Also, are you thinking of listening to the recommendation by the World Health Organization to recount all of the numbers, all of the cases that you have counted so far, in order to avoid a phenomenon like the one that happened in China, in which they had more cases than they had originally thought? Thank you for the question. Yes, today there was a recommendation. Today there was a specific law approved regarding the prohibition of cremation of dead bodies. And this happens to do with a question that was posed a few days ago. It was an agreement that was approved. I had said that there would be an agreement agreeing to ban cremation, but this is specific to unclaimed bodies or unrecognized bodies, and this is very important. The people who have been claimed or recognized by their relatives can be cremated. It's only in the case of those bodies that are unidentified will not be cremated, because they could be there could be someone out there looking for them. And regarding the collaboration between state authorities and federal authorities, well, I think I have just explained it. The law is very clear when it specifies the specific fields and duties of shared responsibility between authorities of all levels. I think we are going really well. There is a federal pact, there is collaboration between authorities, and it is established in the Constitution, and everything is working accordingly. And regarding the World Health Organization, you use the word comply. This is not the way it works. The World Health Organization is formed by sovereign states, and the sovereignty of the organization resides in the association of all the sovereign states. So there is no complying, because we're all free states, right? And talking about the different mechanisms that we have for integrating the information, yes, different countries have different methods. We have explained several times. Dr. Alomia just explained how epidemiological vigilance works in Mexico, and he just went in depth into explaining one of the mechanisms that integrate the overall model that we use. It's a very complex scientific discipline. Good evening. I want to ask about the municipalities that are COVID-free. These municipalities are COVID-free because the state authorities haven't reported any cases? And my question is because of this. Some communities that are appearing as COVID-free are very remote, but they are communities that sometimes are also, they don't have any hospitals. For example, the community of Agua Prieta is very far away from the capital and is very near the border. So it is, I think it is a valid question. Why are these municipalities COVID-free? How are you ensuring to maintain specific monitoring of these cases? What is happening in those municipalities? Also, I want to ask you about the ventilators. We know an agreement was reached with the United States government. How many ventilators will be available when we enter phase 3? And also a clarification. There was a case of a YouTuber who decided to go out even though he was infected, and now there's a, a demand by the population um, for punishment. What are the legal consequences of deliberately going out and exposing people to risk? Yes, okay, let's begin answering your questions. The general health law contemplates the sanctions that a person who knowingly exposes other people to risks, to sanitary risk, may be subjected to. This is not necessarily a practical thing to resolve, but it could be. There could be the possibility of facing um, law proceedings because of committing a crime. And talking about the ventilators, yes, there has been a high-level dialogue between the two heads of state in a collaboration spirit. We had this preliminary um, piece of news today of these uh, possible thousand of ventilators that could come to Mexico from the US. This is not a donation. We will pay for those ventilators. But should the worst scenario should the worst scenario present itself, we would need 15,000 to guarantee. But if we have less transmission, we will need less ventilators. And we also have ventilators currently. And talking about the municipalities, this is a very dynamic process. Today, there might be a municipality that has no cases whatsoever. Tomorrow, that may change. It really depends on the mobility conditions and of whether these populations abide or not by the health distance and the mitigation measures that we have dictated since many weeks ago. So there could be a municipality that has low risk currently because they are abiding by the measures, but maybe they receive a visit in the future from someone from other municipality. This is similar to what happens between countries. Sometimes there were countries at some point that had no cases and they were close to other countries that had cases, but that changed over time. And what are the mechanisms that we are using? Well, Dr. Alomia just explained what are the specifics of the epidemiological vigilance system that we have. To simplify it, we have local health personnel. They provide treatment to patients exhibiting symptoms. They are obligated by law to notify these symptoms and these suspect cases. Before, they would notify it in a handwritten note or a hand-filled format to the relevant authorities, and the relevant authorities would give it to the office state, and the state office, sorry, would give it to the federal offices. But that was like 15, 20 years ago. Since 15 years ago, things are done through our computer, so we can see those notifications on real time. We validate it and we pass it to the other relevant authorities. And when the federal authority validates it, it appears on the national platform. So, okay, I know they are obligated by law, but could it be? Could it be that a municipality that is considered to be COVID free is because these people are not doing their job? Well, it could be for many reasons. And for example, in the very remote communities, how are you going to detect? Well, anywhere there are medical units, we can detect the cases. All right, we have 7 minutes to go. Hello, good evening. 6 minutes. Yes. Talking about the cremation agreement, how many of the fatalities that have been reported so far have been cremated? All of them? And have there been unidentified bodies so far? Also, how long does it take from a fatality that is a suspect case to be confirmed as a COVID case or a negative COVID case? Also, the states of Mexico, Veracruz, and Chiapas appear as highly vulnerable states. Are you concerned about the situation specifically in the state of Mexico? Regarding the cremation of bodies and the disposal of the dead bodies, this is not part of the epidemiological vigilance process. This is part of the clinical medical treatment on one side. On the other side, it is a local authority matter. It is the responsibility of the state authorities. And third, of course, families are free to decide which is the mechanism in which they would like to dispose of the bodies of their relatives. And talking about the vulnerable states, in general terms, the vulnerability, and this happens to do with some question posed yesterday regarding those sections of the population that are malnourished. Vulnerability can be expressed in many ways. It can be vulnerable to contagion, vulnerable to lacking the health services, etc. But I would like to know the information about the study that you are talking about. Talking about the time you asked about, this time that happens between suspect case and confirmed case is not related to the fatality itself. There is a amount of time that has to happen between the gathering of the sample and the results. Sometimes, unfortunately, the person will die in the meantime, but usually we have the results first. Now, if the die, but usually it takes 72 hours. 72 hours from the moment we take the sample to the moment we have the results. Good evening. We've had we'll have doubts from the public regarding cases that are asymptomatic. I was reading an article about how in China 8 out of 10 cases were asymptomatic and a lot of them were related to children. Is this true? Could this happen? What happens with them? Can they be sick for the whole time without even knowing it? Can they transmit the virus even though they have no symptoms? What happens with these cases? The other question is, talking about the specific regions, have you considered having economic sanctions to prevent people from high transmission states from going into low transmission states? For example, have you contemplated fines, for example, like running through a red light? We haven't considered it as a national policy. We know some states and some municipalities within their powers and authorities have applied some administrative sanctions, such as fines. They are in the right to do so. It could be or not. It could or not be helpful to mitigating the transmission. But it is within the right and it is their responsibility. Now, talking about the asymptomatic cases, there could be a person who has the infection and the infection is proved through a laboratory test that is through analyzing the respiratory secretion from the backside of the nose drill by a PCR test. But even though having a positive result, it is possible that this person would not have any symptoms whatsoever. No headache, no coughing, no red eyes, no secretions. And this would be an asymptomatic case. This is known. We have many cases like this ones. In Mexico, we have reported them. Now, how many of these cases, in this case, we're talking about a patient that is infected, but that does not present the disease. Now, how many of these cases is the normal percentage? We don't have clear data on that worldwide yet, but talking about other similar infectious diseases like influenza and metapneumovirus and rhinovirus, we assume that it could be a very significant, very substantial percentage. So it wouldn't be surprising at all that it was an 80% of the overall cases. And we've said this before, it is very likely that a lot of us will get the new coronavirus without presenting the disease of COVID, and then eventually we will reach immunity. Thank you very much. That will be all for today, and we can continue tomorrow. Thanks for listening.